and Happy New Year to those I haven't spoken to yet, although we're half through January. For some reason I can't really recall. Don't know where the time's gone to, but I hope you all had a good break over Christmas. And it's nice to see everybody here today. So we have a couple of apologies. We have one from Shireen. Have we heard from Roger at all? So he may be late, so we'll give him the benefit of the doubt, but we'll carry on anyway. Any declarations of interest or changes to be notified? I have one. I have stepped down from my role as a non-executive director at Derbyshire Community Health Services, and I have updated my declaration, just for noting. Minutes of the previous meeting held on the 13th of November, which feels a long time ago, doesn't it? Any amendments or corrections to the minutes? No? Okay, thank you very much. We have the action monitoring schedule. I think everything on here is either complete or on the agenda. Any questions on any of the actions? Okay, any actions on the minutes that we haven't captured? Anybody wants to raise? No. Okay, great, thank you very much. So we can move on therefore to our patient story. Thank you, Kenny.
Thank you, Chair. Yeah, so I'll introduce this story. So it's stories really, actually. So patient stories from the Diverse Minds group, which is a fairly new group that's been established in partnership between our community mental health services in Leek, but also our ARS practitioners that work in primary care. They did an analysis of some of the referrals that were getting into our mental health services and felt actually there was increased presentation from people who were neurodiverse and felt that there was a gap that they could try to fill and offer additional support through a peer-based support group. And this is the experience of some of the people who have used it. And so I'll introduce it by saying that it is slightly longer than usual patient story, so apologies for that, but I think there's a real richness in what people have to say about their experiences.
This is Cody Lowe, and I attend the Diverse Minds group here in Leek. I'm 20 years old and I'm diagnosed with autism. So I went to see my primary care mental health nurse practitioner, and she actually did advise me to come to the group as there was so little support for autism and ADHD and other related developmental conditions. Very welcoming environment, very autism and ADHD affirming, I would say, and I wasn't masking as much even the first time because I knew I could just be myself, because everybody else at the group has some kind of neurodiversity, so I just thought I'm not weird here. Because I'm in a supported living setting, it can get quite lonely sometimes, so coming to the Diverse Minds group has prevented me from being so lonely, and it's prevented
support.
brilliant timing for us to see that set of stories when we've just done our Oliver McGowan training. So we feel I feel certainly personally much better able to empathise with the issues that people are raising and presenting with. So any questions or comments from anyone?
Chair, I mean, I'm happy to pick up, if people have got questions, happy to pick up at the end, because I've had quite an in-depth conversation with the service leader. People require some further
Thank
detail.
you very much. So I saw all the hands go up, so I'm guessing now. I think I saw Pauline, I definitely saw Rosa and Dennis. Yep. Oh, and Jenny, so you go first.
Thank you. No, I think that actually this is the fourth time I've watched it, because we had it in quality as well. And every time I've watched it, I've made even more notes this time again. And I think, like you said, the awareness and the requirement of just people being able to talk openly about something that I think for me, sorry, I'm mixing my words here quite a lot, but the fact that individuals are still saying, I don't, it makes me feel normal, shouldn't be a thing. They shouldn't, individuals shouldn't have to feel like a space to feel normal. Normal is that individual. And the fact that they are getting that support, it's like, my mind is now, how do you get that out further from just that group? It shouldn't be just once a week or however often they get to meet in that setting. And the fact that they're still saying, I still have that masking. It's like, we're doing great, but actually I feel like there should be able to be more of that, so that the masking doesn't, because it's high energy, isn't it, burning, and that's the issue. So yeah, I think like phenomenal work that is done, and I love the recognition, and every time it kind of makes me feel very warm when they say, this should just be available, that you can clearly see the benefit in those service users. So yeah, how can we make that more easily accessible for people?
Thank you. Pauline.
Yeah, I mean, a very powerful story, and we had quite a lot of discussion at the Quality Committee about it. I think the thing for me is that we know there's an issue about initial assessment, diagnosis, and then ongoing support. I was shocked when the timescale of 5 to 6 years for getting an assessment. I have experience of it taking 3 years on the NHS, but I was quite surprised at that. My other issue was, again, this is a peer support group, so it's and I think that's why it's so valuable, because it is set up and established by people who have lived experience of the things that are being taken there. But it is only in league, and the thing for me is, how do we look to put that out across our areas, other than just that one area? And it's a really good model of how we use our individuals who've got lived experience in the variety of roles that the trust supports, because I know there's different titles and different roles. So I think it's a positive story, but that it clearly demonstrates both things you can do and also the gaps that we've got.
Thank you, Pauline. Rosa.
Yeah, it was really powerful, and I was just reflecting on, so it seemed to be quite sort of relatively low cost, that there wasn't much infrastructure involved within it, and it didn't, require an intensive amount of sort of capacity to be aligned to it. So which made me think, I know that there are skills aligned to it, clearly, that they very much complemented the facilitation support, but it did make me think that could it be an example of something whereby we actually work with our own communities to train people to have those facilitation skills, who may have lived experience of going through this themselves, so that it becomes more sustainable. And we all would want to scale it, but there's still some limitation on what we can potentially do. Our ambition is always huge. But where maybe that could be something that could be explored and may well already be being explored. And it just was so nice to hear the positive feedback and the fact that they were able to get some support despite the other challenges that they'd faced. Thank you.
Dennis, then Martin.
Yeah, I wouldn't repeat what everyone has said. I think it's a very important message that we've had around peer support and leading groups. I do think there are two occasions where they mentioned challenges with adult services. Some of it is quite national and very difficult to deal with. But if I did say at our policy committee when we saw this that if I think back to early years when I was training, use of groups was seen as integral to interventions in mental health, but over time they're not seen as mainstream anymore, and some of it is, even some of them were successful in the past, but still owing to changes in interpretation and resources, these are reduced. But this is quite unique in the sense that it's peer-led. But whilst we can look at how we develop this in other areas and across the community, there will also be caution and challenges to think about how we support those individuals who facilitate them, because there is always that interface between professional support and peer support that they would require. And maybe there are models that we can look at to make sure that we're able to provide that. But the bit about assessment and the delays is a big challenge, but it's not unique to this organisation, and it's a more widespread issue that most trusts are tackling currently. Thank you.
Thank you. Martin.
Thanks. I suppose just a feeling. Firstly, well done to Ruth and team. I don't know if Ruth's with us, but brilliant work, really impactful, and this does give you a real feel around the opportunities within the community, isn't it? One of the service users talked about that social care bit before healthcare, and I thought that was quite a nice summary of kind of this is some of the work that can be done with fellow partner agencies and communities. Acknowledging your point, Dennis, that actually we need to make sure we've got the right support around those that are running the groups, but it's got a real good community need and community feel to this type of work, so yeah, really impressive.
Ben.
Yeah, I suppose, so obviously powerful video. I suppose just a bit of context and reminder to some of the boarders. Obviously we didn't have an adult service in Stoke-on-Trent and Staffordshire 18 months ago. It didn't exist, and we were given very limited funding to bring in a service that's commissioned to treat just over 300 patients a year. Now, I don't think any of us like talking about we're only commissioned for X, but it's quite important in this case because we started taking referrals a couple of months before the service went live, and on the go live date it got more than a year's activity sitting on its books. So that's why we've seen such an exponential rise in waiting times. And like Jenny says, that's not unique to us, where I think it's probably we're feeling it a bit more because we didn't have anything before. But we do continue to look about how we can improve the service, and I was only talking to Darren yesterday actually about some tweaks we could make that would potentially increase some capacity, but also exploring the changing sort of job market and availability of skills. So one of our constraints has been the availability of skills. Actually, there's some potential out there at the moment with some of the changes to resident doctor recruitment and roles, etc. There are potentially some people out there, but also we recognise we've got a system that's got its financial challenges and there's reticence. So I think it's just to give some concept that we continue to look at this wherever we can improve and engage wherever possible. But like many people have already said, this is not a challenge that is going to go away lightly or is going to be a quick fix.
Thank you, Ben. Russell.
Yeah, I think the thing that struck me most actually was just how articulate everybody was.
Yeah.
And that was just, shouldn't be surprised about that really, but it was great to see, and it made me remember that we need to be tenacious about getting lived experience into the board meetings as much as we can.
Yeah.
Really, I'm really delighted that we've got Shireen, but when she's here, but I think we just need to continue to be really to pursue that really strongly.
Thank you. Roger.
I think I might have said this in Quality Committee. With regards to people who are sitting on waiting lists for diagnoses, some of the most useful work is done pre-diagnosis, pre-diagnostic assessment and support. We've built that in processes in Wales, and also in the past when I looked at a national audit on autism diagnostic services, some of the most effective supports were coming from non-NHS organisations, charities and others. I seem to remember in Reading was one of them, who were the first point of contact, and actually were doing those questions of why now, why is it important to have a diagnosis, what else is going on in your life, what are the problems that it's causing, and many of those things can be looked at and supported without actually having to have the diagnosis. The diagnosis is later down the line. So I think when we're thinking about revising pathways, I think front-loading the stuff that actually addresses what people need is as important as actually getting an accurate diagnosis.
Thank you. Kenny, anything you want to respond to on all of those points?
Yes, I think I would agree with what everyone has said. You know, there's a national issue here, isn't there? And the Secretary of State has asked for a prevalence review, particularly into these sorts of presentations to be undertaken, so we understand the sort of national position. So it's not necessarily a local issue. There's massive variability in the provision of services for neurodiverse people, all the way to diagnostics, but other, as Roger said, other parts of the pathway. So that's the sort of national presentation. In terms of what we've done locally, so I think a few people have rightly asked, well, what next? The ARS practitioners, the intention is that they will work across the locality to look at the feasibility of establishing this sort of group across Stoke and also Newcastle. I think someone talked about on the video, it started with a few people and now there's 20. I think that will continue to grow because the demand is there. So we need to look at a few things really. We need to look at how this aligns with the sort of diagnostic formally commissioned service and make sure that there's a clear pathway and route for people. We need to make sure it's sustainable, so actually we can meet the need, and I think we could be soon overwhelmed unless we really attend to that. And then one of the asks of the service is just having some places to facilitate these. There's real pressure on community resources to be able to run these types of groups. So I said I would speak to Ben about how we might be able to support that from a non-pay perspective in terms of being able to facilitate those groups to grow as they get there. And they've already had conversations with Port Vale in terms of thinking about running one in the north of Stoke. So it's in train, but we just need to do a little bit more support to help them get there.
Thank you for that. One of the things I wrote down was scale and addressing demand, because you can just see this is so successful, and word of mouth is going to be dramatic in getting people to say, well, I want to come, and the worst thing we could get is a very successful service saying, sorry, there's not room.
Yeah.
So I think you're absolutely right to think about those things. And just a matter of interest, I went to a mental health group which is combined is represented at it, but it's mainly voluntary sector. And there was somebody from Keele there saying that she was applying for funding to do some research work into what it's like to be on a waiting list, so what the impacts are for people. She was hoping if she gets the funding, obviously she's going to be coming to us and to MPFT because she wants to do it, focus on Staffordshire. So just to give you the heads up that might come down the line, I thought a really worthwhile piece of research for us to be part of. So, sorry.
I just wanted to make one final comment really, in that whilst I think this is a wonderful group, and I'm really supportive that we look to extend that and see how we can support this type of thing, I also do want to ask us a bit of assurance about, well, how are we trying to deal with that waiting list? Because the reality is, for quite a lot of people, they do need that diagnosis and they need the medication. And they won't get the medication, of course, until they've had the diagnosis. So I suppose there is also that part of me that wants to know, what are we doing to try and address that side of it? And I know it is a national problem, but I'm just putting that there to sort of keep our minds balanced in terms of what this offers, but actually we've definitely got to get that assessment and diagnosis and treatment in terms of medication.
Please,
Yeah, so I think there's two things. There's making sure, as Ben said, that we are focusing on making our pathway with the resources that we've got as efficient as possible, so we get maximum value out of it in terms of the resource. And that, I think, will include this, because actually some people, as Roger have said, may have their issues resolved without a formal diagnosis if actually we give them the support, advice. Some people may still want and need a diagnostic appointment and a diagnosis, but actually there's something about, as Roger said, front loading and being able to make sure people get support as quickly as possible. And then the second thing is actually continuing to raise the issue about the lack of resources that as a system we have for this group of people, and making sure that it is continuously raised in our planning for what the priorities need to be for the system. So yeah, I think there's two key elements to it, really. And the one thing, Chair, if you'll indulge me, I should have said, was I think we do need to spotlight this as positive practice and share with others, because this is, like I said, this isn't just a Stoke-on-Trent, Staffordshire issue. People are thinking how we can improve these sorts of experiences for people nationally, so I think we need to do that too.
Yeah, we absolutely do. And we do have our waiting well interventions as well, don't we? So we don't just leave people sitting on a waiting list, we are interacting with them. Joe?
Just so you know, on that rating profile bit, so obviously this is a 13-minute film. There's a shorter version of this film which also includes, because some of the participants didn't want to be promoted on social media and all that sort of stuff, so we've got a shorter version which includes everybody who's given permission, so we will be making that available as well, and it'll be on the meeting page as well.
Okay, thank you. So very positive intervention. Very much supported by the board in the context of, in an ideal world, we would do something else additionally as well, but we can only work with the constraints that we have. And I think raising the profile of this for other organisations is really important, because we have some very good practice here and we should share it. So thank you very much for bringing it to the board. Very enlightening and great for the people who are involved. So, Reach Recognition Award. Bucky.
Thank you, Chair. This month's Reach Recognition goes to Debbie Bowie, who's here with us. And as always, I just need to focus on what people have written about you to ensure that you get the full benefit. Otherwise, I might deviate and forget to say the important bits. So, Deb leads the development and delivery of safe, effective and efficient transition pathways for children and young people aged 14 to 25, moving from children's to adult mental health services across combined. Deb works across CAMS, inpatient services, crisis and home treatment and learning disabilities team, ensuring that care transitions are smooth, timely and person-centred. Deb has recently, at short notice, stepped up into the service manager role to support our ASD and ADHD services, and her leadership is making a real difference, improving experiences and outcomes for our service users and staff. Deb has gone above and beyond her core role in several ways, delivering tangible outcomes that have made a real difference for children and young people, their families and wider system. Deb has developed and embedded transition pathways, led SEND integration across the Trust working with ICS partners to meet statutory obligations and improve support for CYP with additional needs. Co-produced solutions with families and partners, including active engagement in the Send Community Lounge, where parents reported feeling supported at the right time. Positive parent feedback highlights immediate resolution of issues and improved access to services. A quote was, "I was truly amazed by the whole setup and by every service that turned up to give families the chance to have the proper one-to-one support." Youth collective involvement. Deb championed sustainable community youth provision, secured community grants and contributed to the youth strategy development to enhance mental health support. Can you all join me in showing our appreciation?
Well done, Brad. You have to have your photograph taken on the wall this way. You've done an amazing job, and how appropriate that you should get your award today when we've just been looking at the issues around ADHD and autism. So there you go.
Thank you.
Okay, there you go.
Well done. Did you have any thoughts listening to those videos and watching those videos that you wanted to add based on your experience?
I want them to come and talk to the teams, definitely. I think, I mean, it's fantastic, and I think what Pauline said is about it being across the whole patch as well. We are looking at, obviously, we have got some post-diagnostic support. The waiting well is an issue. You know, that there's so many people on the waiting list and capacity, and we are looking at how we can tackle that, and I think it is looking at how efficient the teams can be with what resources we've got as well. But there are some plans as well with the post-diagnostic support, particularly with the autism, to have a sort of coffee drop-in and for people after diagnosis, so that would fit in really well with the diverse minds group. So yeah, it's brilliant. I'm just thinking about how we can all link in. Wonderful.
So, yeah, it's exciting, isn't it?
It is, yeah.
Brilliant. Thank you very much.
Okay,
Thank you.
thank you.
So, Bookie, Chief Executive's report.
Thank you, Chair. I'm taking the report as read because it highlights and spotlights a number of things across the trust that has happened, but I wanted to draw out a number of things in there. Some of them we'll discuss some more when we have our IQPR, but thought again important to highlight, like the out of area performance. It's becoming a real issue for us from nothing virtually, and it's just a problem that we need to tackle. So we will talk some more about that later. I did want to spotlight Dr. Becky Chubb at Parliament with Joe. I thought that was a real good opportunity for us to shine, and really appreciated that. I also wanted to spotlight another visit to dementia services, just again showing more about what we do already at Combined. Other than that, I'm happy to take any questions and comments.
Thank you very much. Any questions or comments for Bookie on the report? Lots of good things going on. Good to see. And well done, Joe. I think you fulfilled a lifetime ambition as well as going and highlighting the trust, so double benefit. And it's great to see that we continue to innovate so well in this organisation. Ben and I had the pleasure to go and visit the mental health liaison team yesterday. Care team, yeah, care home, sorry. Really interesting group of people, full of enthusiasm. And I said to Bookie earlier, sometimes we have difficulty getting people to talk to us when you go on board to team visits. We couldn't get a word in edgeways, could we? We overran considerably, yeah. But it was a great example of innovation in the organisation to change something that wasn't working. And so powerful when that change comes from the team that's delivering the service, rather than having it done to them by people who don't necessarily know the issue. So very, very powerful. But I think in context with your report, it's just another example of how well we do that. Anything else for Bookie while you've got her undivided attention? Okay. So in terms of my report, sorry, there's nothing in writing, but there's been a bit of a gap with Christmas in the middle. So just a couple of things I wanted to mention, particularly to thank people who worked over Christmas and people who struggled to work when it snowed. Lots of people have the opportunity to stay at home and work from home. A lot of our staff just can't do that. So real recognition, I think, for people who have worked over the holiday period. The other thing was I note on the screensavers, we're still offering vaccinations. Just to our staff, if they haven't had one, please think again about having a vaccination to keep yourself safe and keep your patients safe. And I see that also we are promoting the Pulse survey for staff to tell us what they think. So please use the opportunity to tell us what you think. So I didn't have anything else other than the things I've mentioned, but if anybody has any questions for me, that's fine. Yes, Kenny?
Just a comment, Chair.
So as of today, I think we've met our stretch target that NHS England gave us for our flu vaccination campaign. And we are the highest vaccinator of any mental health trust in the Midlands. So it has been a successful flu campaign, but we can always do better. I'm sure we'll be asked to do better next year.
Yeah, no, well done though, that's great to hear. Why am I not surprised? So we have a couple of questions from members of the public, which Ben is going to deal with for us. Thank you, Ben.
So obviously I won't go through the questions because they are in the papers, but just obviously one we can respond to, one we can't, but I will give board members just a little bit of background, and we have referred that one on. So the first one is relation to ARFID, and of course we will feed back directly to Healthwatch. But ARFID isn't actually included at the moment within the NICE guidance for eating disorders, and there aren't actually any national guidance in relation to children and young people. And it's also a condition that can present at many levels of severity, which means many of them won't actually need to be in a specialist eating disorder service. So our sort of current ARFID offer is covered by a number of services at the moment, so specialist eating disorder, but also community peds, community dietetics, CAMS, CYP learning disability, our autism teams and our community CAMS team. So we do offer aspects of that, but there isn't a single route. But of course, as an organisation, we do take the approach wherever possible that we don't have a wrong door, and we will then make that effort to move it into the right team. But within our eating disorders, for the higher end ones, we do have an ARFID pathway for assessment and mental health interventions, both for the young people and for the parents as well, because that's an important part of that offer. And then that's followed by an information gathering and screening process, which allows us to link in where the person goes. If the young person is already under the care of another team, quite often that will be by a consultation in, rather than moving them out into a different team and disrupting their care. So there is a range of offers there. It's not a single offer, and there isn't a single offer prescribed nationally either. So we will help feed that back to Healthwatch, but I don't think we can give them a nice clean package that they necessarily would want. Anything on that from anyone wants to add?
Yeah, thank you, Ben. I was just listening, and you talked about we have a policy of no wrong door, and I wonder whether there is something we need to do to make sure that we continue to reiterate that and assure ourselves that that is actually what is happening across all our services.
And that's why I want to reach out to Healthwatch as well to see if they've got any feedback that says that isn't happening, because that would be quite important.
Because this has been raised presumably because of an issue, as opposed to a casual inquiry.
Yes. So
Yeah.
I'm assuming so.
Okay.
And then obviously the second question is in relation to GLP-1 drugs, so Mounjaro in this instance, and we have referred this on to the ICB because obviously it is their policy and their decision process. But I thought, as we've got the question here, it was worth just giving a bit of background for board members to help them understand. So Mounjaro has been approved by NICE, and normally when they approve a drug or a technology, the NHS has a 3-month time period in which to roll it out by law. In some instances, it's 30 days if it's a rapid one. NICE, in the case of these drugs, has issued a derogation and given the NHS 12 years to roll it out. 12 years. In relation to both the volume and the cost to the NHS as a whole. So I suppose that I thought it was important to get that context out there because it just shows what challenge this is. The ICB has followed the NHS England national guidance for this. So basically, you have to have a BMI of 40 or over, or if you're in certain ethnic groups of 37.5 and over, and you have to have 4 out of 5 defined additional conditions to go with that. And the model that they've adopted locally is there will be GP hubs which are run by PCNs, and they will go out to the patients directly, which is why they're asking people not to contact their GP over a period of the next 12 months to deal with that very smallish cohort actually, and then there's a rollout plan that runs forward for up to 12 years, which is an ICB responsibility. So although we are aware of that at a high level, we have redirected the person to the ICB, but I thought it was just helpful for board members to give a bit of context. And of course, one of their questions is, who is the regulator of the drug? And of course, that is the MHRA.
That's really interesting. I wasn't aware of that. I must admit that it was that, the requirement was that exacting. Any questions for Ben on that? Thank you very much.
I suppose just for any member of the public who happens to watch this bit, those criteria are on the ICB's website if people want to go and look at them.
Okay, thank you very much. Thank you. I'm going to keep going for a little bit further till we have a break. So, Penny, are you okay to